One other topic that was covered in various presentations at ASCO, but not in my mind a definitive one to change practice, was the concept of using liquid biopsies, so-called, and circulating tumor DNA to predict for subsequent response or relapse. And this was touched on in several small trials. And Ben, you gave a very elegant summary of several of these and some of the potential utility and caveats, the limitations of this work. Can you speak to this? Because my sense is that the data have been very consistent in showing that a blood test and circulating tumor DNA has a lot of potential in preceding imaging in telling us about response and progression, but not as clear how to use this. I don't see it replacing imaging. And you also brought up some issues like cost and various things. So what is your impression about where it is now and where you think that circulating tumor DNA and blood tests to assess the status of disease in lung cancer is going?
Yeah, I think the data is very compelling. It's excitement. It's unique to think that we could essentially use a simple blood test to tell how the patient is doing. And the data that we had from large trials with both EGFR-directed therapy and ALK-directed therapy suggests, as you said, that drops in plasma with a particular mutation seem to correlate with responses quite nicely, and even also rises in the plasma seem to precede what we see on CT imaging. But there are a lot of caveats, and I think number one, we still need standardization of the commercial assays that we're using. We need prospective data, and this was my call during the talk, is that we really need more prospective data to understand, can this truly inform treatment decisions? If patients don't have a drop, does that mean we should switch therapy? And if patients have a rise in their mutation, but the CAT scan is still stable, does that mean we need to switch therapy? So I don't think we're by any means ready for prime time. I think there's a cost consideration as well, but I do think this has serious traction. And I think if the right trials are done, we may be able in the next 3 to 5 years to use this and help inform treatment decisions. I know in our own group, we're mulling around the trial. I know Charu has some trial looking at drops or rises in plasma with immunotherapy. So I think we need more prospective work. It's kind of the theme of the data we've talked about, but certainly very exciting as we move forward.
Yeah, Charu, you have been one of the leaders in plasma testing. I'd love to get your impression of how you see this playing out in the coming few years.
So I was very encouraged by the emerging data with circulating DNA monitoring in not just EGFR mutant lung cancer that we've seen, but as Ben elegantly presented in ALK rearranged lung cancer as well. And I think the theme is similar. You know, can we identify these patients that are destined to not have the best PFS that we could, or identify these persister patients with persistent cells, and perhaps come in with, you know, an additional therapy, be it chemotherapy or radiation or some other approach to prolong that progression-free survival. Similarly, in our experience, we have noticed that patients are started on immunotherapy as a monotherapy for, let's say, these high PD-L1 patients. We tracked their plasma, and this was presented as a poster at ASCO, and we found that patients that had a decrease in their VAF really had significant improvement in their PFS compared to patients that, you know, had persistent mutations or an increase in their variant allele fraction change. So I think, you know, there is something there. How would I apply this information? Right now, I think we should design clinical trials around this. There are a lot of issues. We are doing these tests in the research setting, and how do we even broadly apply these tests? There are cost issues and there are reimbursement issues. So I think we have to be very mindful about that. You know, we often talk about, Jack, that most people don't even get baseline testing, to really now ask for, you know, Q9 week or Q6 week testing on these patients is, obviously a big challenge. But I do think that these should be incorporated in future clinical trials, and there's definitely, data to guide those trial designs.
Yes, I think it's exciting, and the data have been very convergent in supporting this, but cost is an issue, and as accessible as it is, if it costs more to do this than to do scans, then I think that's going to be a real limitation.